Violence against women has arguably been largely ignored and normalized by policymakers and the public. In the aftermath of Dobbs v. Jackson Women's Health Organization, restrictive state abortion policies have made it all the more urgent to address the contribution of violence to unwanted pregnancies and to injury and death during pregnancy and the postpartum period. I'm Stephen Morrissey, managing editor of the New England Journal of Medicine, and I'm talking with Elizabeth Tobin-Tyler, an associate professor at the Brown University School of Public Health and Warren Alpert Medical School. Professor Tobin-Tyler has co-authored a perspective article about the connections between pregnancy and violence. Professor Tobin-Tyler, what's known about the frequency of intimate partner violence and sexual violence in the United States?
Well, it's really distressing when we look at the statistics, both regarding sexual violence and intimate partner violence. What we know is that 1 in 4 women are raped during their lifetime, and 1 in 4 also report experiencing sexual coercion. We also know that about 1 in 3 women in the United States experience intimate partner violence. And so when you look at those statistics, it's pretty striking. And we actually looked at the data regarding peer nations with the United States, so from the Organization for Economic Cooperation and Development. And the rate of violence against women in the United States is 56% higher than the average among those peer nations. So violence in the United States is a significant problem.
And how are violence and abuse related to reproductive coercion and unwanted pregnancy?
One of the reasons we wanted to look at this in particular, especially after the Dobbs decision and 14 states implementing abortion bans, is to understand the role of violence in pregnancy. And given particularly the high statistics that I just talked about, my colleague and co-author, Dr. Sam Dickman, and colleagues had produced a study a few months ago where they looked at government data and essentially were able to estimate that there are about 64,000 rape-related pregnancies in the states that have abortion bans, so the 14 states that have implemented abortion bans. That's an astonishing number when you think about what that means for unwanted pregnancy, and even more importantly, I think, violence-related pregnancy. So we're very concerned that as states are implementing these bans, of course, it's draconian and cruel to require somebody who has experienced a pregnancy because of rape to then not have reproductive choice and be able to make decisions about what to do after that pregnancy.
And as you say in your article, once pregnant, people in abusive relationships are at even greater risk for violence. So why is the peripartum period an especially dangerous time?
We don't know exactly. I've done a lot of research on intimate partner violence, and it is clear that particularly the rate of homicide is much higher during the peripartum time for people that are in relationships where there is abuse and violence. Peripartum people are about twice as likely to be killed who are experiencing intimate partner violence as non-peripartum people. Part of it is that relationships that involve abuse and violence are really about control. And so we think that there is something about the peripartum period that indicates to an abuser that they are losing some of the control that they have maintained over their partner, and that may lead to more violence. That's one theory. We don't know exactly why that is, but what we do know is that violence is much more significant during the peripartum period.
And then how does access to abortion affect the safety of people who are in that sort of situation?
So those that are in relationships involving violence, if their reproductive choice is limited, then they essentially, particularly if they become pregnant, they're not only more in danger of escalating violence and homicide, but because these are controlling relationships, it's much more difficult for the person to leave that relationship, particularly when somebody has a child and they're tied through that child to their partner. It is much more difficult for them to escape that relationship. And so that adds to the significance of the violence. There is another study as well, the Turnaway study, that looked at actually people who attempted to access abortion and people who were actually able to receive abortions. And the people who attempted to access but were unsuccessful in accessing abortions, if they were in relationships that were abusive, they were much more likely to continue to experience abuse and violence in that relationship than those who may have been in a violent relationship but were able to obtain an abortion. And so we know that not being able to make the choice regarding reproductive health and accessing an abortion has significant ramifications for somebody who's in that type of relationship.
The Supreme Court recently issued its decision in United States versus Rahimi. How will that decision affect the risks related to intimate partner violence, including among pregnant and postpartum people?
That decision is obviously extremely important. What the court had to decide in that case was whether or not a federal law, which essentially says that if a person is subject to a domestic violence restraining order, they should not be able to possess or purchase firearms. Those laws are carried out at the state level. And so they're extremely important in protecting survivors of domestic violence. The court upheld that federal law and essentially said that that law is not a violation of the Second Amendment rights of a domestic abuser. And they did that following a case called Bruin, in which the court made it very difficult for the government to argue on behalf of particular gun regulations, including something like a gun regulation regulating whether or not domestic abusers may have firearms. So it was a good decision that they were able to sort of get around the logic in Bruin and decide that in this case, there was significant history, or they were able to point to history and tradition, which was their test, to determine that domestic abusers could have to relinquish their firearms. What I would say about that decision, though, is that doesn't change the status quo. All that decision does is maintain the current federal law and the current system that we have of states and state courts carrying out those orders. And so there's good research out there that suggests that it's incredibly variable across states, whether or not domestic abusers are relinquishing their firearms, but also whether courts are actually even implementing those orders. And so I think it's important to recognize that that was a good decision. And lots of us had a large sigh of relief when that decision was made. At the same time, it doesn't change the status quo. And as I said earlier, the statistics regarding violence against women are significant and have been significant for a long time.
So, speaking of statistics, you say in your article that to develop evidence-based solutions to the crisis of violence against women, researchers and policymakers need access to data that are comprehensive and accurate. So, in what ways are current data lacking, and how could data collection be improved?
One of the things my colleague Sam Dickman and I were looking into, and he's done a lot of work on trying to pull this data together, is that some of the data sets that are commonly used to try to calculate these numbers that we've been talking about haven't been updated in quite some time. So, for example, the National Intimate Partner and Sexual Violence Survey, the data available goes back to 2016. And particularly in this time post-Dobbs, it's really important that we have good, as accurate as possible, data regarding violence against women so that we can actually measure and continue to track what is happening. The other thing about this kind of data is that it can be very complicated to collect because it's a very sensitive area. And so it's really important that researchers that are trying to get a handle on the number of people who are experiencing either sexual violence or intimate partner violence, that data is collected in a very sensitive way, understanding that people often are not willing to speak about this because of the sensitivity and stigma around it. And so we'd like to really see a lot of effort put into thinking about not only how the data is collected, but also that it's updated in a meaningful way so that we can actually track the problem.
Finally, what role can both clinicians and policymakers play in protecting people who are at risk for or who have experienced intimate partner violence or sexual violence?
And I think we'd like to see really more coordinated, integrated care for people who experience intimate partner violence and sexual violence. There are really terrific rape crisis centers and domestic violence advocacy organizations that work in virtually every community, but oftentimes they're quite separate from the clinical setting where often this is where survivors come for healthcare. And so really thinking about a coordinated system of trauma-informed care is vitally important so that survivors are able to navigate the kinds of support services that they need, both in the clinical setting and in the community, but also for data collection, for really being able to understand what's happening on the ground. Having better coordination between community-based services and clinical settings is really critical. The other thing we talk about in our piece is that in many cases, particularly for sexual violence survivors, if they seek out clinical care, healthcare, which most do, oftentimes they get charged for that. They actually incur costs for their care related to violence, to sexual violence. And that seems really draconian and cruel in many ways, that somebody experiences something like rape and then they later incur costs for having treatment to support their needs after that happens to them. Part of that is because even things like state victim compensation funds, which are intended to support victims of violence, often they're not fully funded. And so there may be obstacles for survivors to actually obtain funding. And often there's claim denial. So again, this is a stigmatized area where oftentimes it's challenging for a person to be heard and to be listened to and to be believed. The other thing we talk about is Medicaid. We did a lot of comparison in this piece, particularly of the states that have abortion bans. And among the 14 states that have imposed abortion bans, about 4 of them still have not expanded Medicaid. And some of the states that have even 6-week abortion restrictions, which in essence acts very much like a ban, have not expanded Medicaid. And so Medicaid is a critical support in terms of covering the costs that people might need when they experience either sexual violence or intimate partner violence. So I think the bottom line for us is that we really think at a time where states are constricting reproductive decision-making, reproductive health services for people, they should not also be having to pay out of pocket for healthcare that they basically need because of the violence that they've experienced.
Thank you, Professor Tobin-Tyler.